இவர்கள் காற்றில் மக்களுக்கு தொந்தரவு கொடுத்துக் கொண்டே இருந்தார்கள்.
हम्म। चलिए आ गए हम भी।
गुड इवनिंग सर। गुड इवनिंग सर। उदयपुर में पीछे से म्यूजिक चल रहा है सर।
मजा लीजिए और क्या कीजिए।
तो पूरा वो ग्रुप का जो ये है, हम लोगों का जो 150 विद्या अपना स्टूडेंट वाला पीएमसीएच वाला ग्रुप है, सब
हाँ,
उदयपुर के एक रिजॉर्ट में जुटे हुए।
ठीक 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 ठीक।
इंटरनेशनल फ्रेंड सब सब यूके यूएसए सब जगह से पधारा हुआ है सर।
हम लोग तो नहीं जा पाते, हम दूर दूर दिक्कत होती है, you know।
नहीं वो तो थोड़ा तो है ही ना सर, दिक्कत तो है ही। अब इस उम्र में बहुत जर्नी करना संभव नहीं है, लेकिन जहाँ जरूरी है वहां तो जाना पड़ेगा सर।
तो कोटा वाला कैंसिल करा दिए।
नहीं वो तो ठीक है, उसमें ऐसा कोई एसेंशियल नहीं है। और ये भी है कि है जहाँ हम लोग है ही सर, हम लोग।
प्रणाम सर।
गुड इवनिंग सर सर।
गुड इवनिंग सर।
सर म्यूट है लगता है।
ना, भूल गया।
तलवार सर गुड इवनिंग।
हेलो।
गुड इवनिंग सर।
हेलो सर, गुड इवनिंग, गुड इवनिंग।
गुड इवनिंग डॉक्टर तिवारी, कैसे हैं आप?
ठीक है सर, ठीक है।
आप तो ओपन एयर से कर रहे हैं। सो कब, आई थिंक चेक कर लें क्या? शेयर करके देख लूं मैं
जी जी
स्क्रीन?
जी जी, कर
हाँ
लीजिए,
सर हाँ
कर
सर।
लीजिए।
वही मुझे लग रहा है कि एक बार वो शेयर कर लेता हूँ स्क्रीन। दिख रहा है सर क्या?
ठीक है, फर्स्ट
यस सर।
क्लास, फर्स्ट क्लास दिख रहा है सर।
चल रहा है ना?
हाँ
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 यस
हाँ।
सर यस सर।
ओके, बढ़िया, फिर डन। थैंक यू। मैं वापस कर लेता हूँ, स्टॉप शेयर। ओके।
सर ये नया एक्सपेरिमेंट किए हैं पीजी लड़कों के लिए, बढ़िया से
बहुत
पढ़ाई
अच्छा किया
करने का,
सर,
सब सब्जेक्ट की पढ़ाई करने के लिए।
बहुत अच्छा किया सर। बहुत ही अच्छा एफर्ट है और बहुत ही अच्छी मेहनत है आपकी इसके अंदर जो लग रही है। इट्स अ वेरी गुड एफर्ट, आई मस्ट से इट्स अ वेरी गुड एफर्ट।
अब मिलिट्री वालों को भी जोड़े हैं, मिलिट्री वाले मिले हैं, हम
अच्छा,
कहें भेजिए सबको, वो लोग भी जुट रहे हैं आज से।
सबका फायदा होना चाहिए।
जी जी जी।
Yeah, Kamlesh Tiwari.
Also, who is giving classes?
This man,
Hmm?
Deepak Talwar.
Huh? Hmm?
Hmm.
क्या डीपी शुरू किया जाए? 7:30 तो बजने चला।
2 minutes more.
ओके। Now we can start, DP.
Yes, sir.
Good evening, friends. Now we have entered into the second week of this short certificate course, and today is the day of respiratory system. The speaker is no other than Dr. Deepak Talwar, international famous speaker for the chest disease. So he is going to teach you bronchial asthma. Now, Dr. D.P. Singh.
Honorable Dean Dr. Kamlesh Tiwari, sir, and ladies and gentlemen, whether our president has joined, Dr. Jyotirmay Paul.
Can't see.
It's my pleasure to introduce our distinguished speaker, Dr. Deepak Talwar, Director and Chair of Pulmonary Sleep Center and Critical Care at Noida Metro. Dr. Deepak Talwar is a renowned expert in the field of pulmonology and sleep medicine with a long list of impressive credentials. He is a fellow of American College of Chest Physician. He is a fellow of Indian College of Chest Physician. He is a fellow of Sleep Disorder Association. He is a fellow of Indian College of Allergy and Immunology with an impressive track record of over 241 research papers, more than 5,000 citations. He is a leading authority in his field in this field today. He will share his expertise with us, and he will talk about the topic bronchial asthma, pathophysiology, diagnosis and management. And you can ask any questions from him with the latest GINA guidelines and others. We are fortunate to have Dr. Talwar with us today, and I encourage you to take advantage of this opportunity to learn from him. Please feel free to ask any questions you may have on bronchial asthma, and Dr. Talwar will be happy to address them. Without further ado, please join me in welcoming Dr. Deepak Talwar. Over to Talwar, sir.
Thank you, sir. Thank you, Dr. Kamlesh Tiwari, ICP Dean, API Bihar, Dr. DP Singh, and having me here today to talk about asthma. This is a continuous educational program. So can I share my slide?
Yes, sir.
Yeah, just give it to me. I think the backend team has to allow. Yeah, I think I'll be able to do now. Correct. What's happened? So it's not sharing, I suppose, huh? Let me try again. Yeah. Is the slide okay now?
It's okay.
Okay.
Fine, sir.
Thank you everyone from API and ICP. And this is the topic which is given to me today is bronchial asthma, and I will try to cover in next about 45 minutes whatever is new and whatever perhaps is of importance to physicians in their daily practice. We know when we talk about asthma, it's a problem because of its huge burden. We know worldwide nearly 350 million people suffer from it, and 1 out of 10 patients do belong to India. So we have a disproportionately high number of patients of asthma in India. And the sad part is that more than 20% of total deaths which occur all across the world due to asthma actually come from India. So that means India has a huge burden, not only of the disease, but even mortality related to the disease about it. Particularly when we are talking about asthma, we don't expect death, but death continues to haunt the patients of asthma, and it is still a common thing to see in a country like ours. So in a brief, the beginning, I would like to just bring one particular point to make things more clear to everybody, that where does asthma attack when we talk about lungs? So we already have learned that asthma predominantly affects the large airways, which comes up to 1 to 8th generation of our bronchi, and then some of the medium sized and even the small airways, which are normally considered as very silent zone, but now there is increasing evidence that they also get affected in patients with asthma. So it's not only a large airway disease, but predominantly large airway disease, which affects even the lower down, the smaller airways, which is like generations from 9 to almost like 18 to 19. So how do we define asthma? So in a quick way, we know that how the airway looks like normally, and when there is a constriction, we get an asthmatic airway, but constriction is not the only thing. There's a lot of swelling of the airway epithelial mucosa, and there is a lot of plugging of mucus, which is trying to further reduce the lubal of the airway and causes the airway to get access into the different parts of the lung with great difficulty because of this narrowing. But the important thing is that it's a heterogeneous disease. So all asthmas in all people don't look alike. Some of them suffer much more than the others, and some of them most of the times might be living a life of an intermittent asthmatic where attacks come only maybe once a year or once in 2 years or even more infrequently. So historically, when we look at it, that how do we define asthma, then I think the most important thing is that it is a disease in which the predominantly symptoms are respiratory, and the most important respiratory symptoms are shortness of breath, wheezes, and chest tightness with or without cough, which is mostly dry but may be associated with scant sputum. But the important hallmark of asthma is that these kind of symptoms do not persist throughout the day, throughout the week, throughout the month, throughout the year, throughout the life. So what is the highlight word there? That it varies. So the symptoms vary over a period of time, both in intensity as well as how much is their expression and trouble which they give to the patients. Along with these respiratory symptoms, there would be expected that the airways are getting narrowed, and this narrowing happens during the expiratory phase, and that will also be variable. So you can see that variable respiratory symptoms, variable airflow limitation or airflow obstruction is the hallmark of asthma. So these patients have good days and bad days, and these patients will have respiratory symptoms and no respiratory symptoms or minimal respiratory symptoms, and they may demonstrate an airflow obstruction or limitation at the time when they have symptoms, or at times when they don't have symptoms, it might even look normal. So what we need to see is that this disease, which is heterogeneous, is basically an inflammatory airway disease. And it's a chronic airway inflammation, as the inflammation doesn't go anywhere. It is only the symptoms and the obstruction which vary, but the chronic airway inflammation persists once the asthma has set in an individual. There are certain red flag symptoms in asthma. So any patient who comes with respiratory symptoms has got these signs then or symptoms, then you need to be very cautious about it. Like flaring of nostrils. What that means, the respiratory distress is very high, but particularly very important in children, trying to suggest that the airway obstruction is very severe and can be even upper airway obstruction. Blue or gray skin around the mouth indicates cirrhosis, and even the skin getting pulled, and then there is excessive movement of the rib cage, which all indicates that there is an impending respiratory failure which is happening, perhaps because of the respiratory muscle fatigue, and patient might have been suffering from symptoms for a little longer period of time. So that brings us to that asthma is a chronic inflammatory disease. And how does this chronic inflammatory disease of the airways look like? And what are the basic cells and cytokines which cause this? So if you look at this picture, you can very clearly see that there is a smooth muscle at the subendothelium level, and you know that there is a smooth muscle constriction which tries to narrow down the passage of airways and producing hindrance to the free flow of the air. So this smooth muscle gets thickened in asthmatics, and it is much stronger muscle which contracts and leads to marked reduction of airway lumen. But what ultimately leads to or cascades to the pathophysiology which happens in patients with asthma is the environmental factors which stimulate the respiratory epithelium. It can be smoke, it can be some allergens, it can be non-specific stimulants, and they go and sit onto the respiratory epithelium, where they lead to lot of irritation of the goblet cells, leading to development of mucus which comes into the airways. And then there are various cytokines which are released into the subepithelial space, which are interleukin 4, interleukin 5, interleukin 6, and many other like interleukin 13. They all orchestrate an inflammation which is called eosinophilic inflammation or a neutrophilic inflammation, which ultimately leads to a lot of damage of the subendothelium and causes a lot of fibrosis there, which makes airway nearly rigid over a period of time and produce what is called as fixed airway obstruction. So I think you can realize that when the airways are recently attacked by the asthmatic process, then there is a reversibility. But if it goes a very long time without significant good treatment, it will lead to more and more permanent remodeling of the airways, and then they behave like COPD because there is a very little response to bronchodilators. And we do know that variability is a very important aspect, but remember that variability may not be present at all times because asthma is a variable disease. So one of the key things to pick up the diagnosis of asthma is a defining variability in asthma, and GINA 2024 has made a lot of clarity onto what do they mean by respiratory symptoms variability. So this needs to be defined historically. Like patient had history of wheeze, shortness of breath, cough and chest tightness. Generally symptoms are multiple, but they vary over time and intensity, and mostly they are in the night, or they become worse in the night or at the early hours of the awakening, like around 4 to 5 a.m. in the morning. These respiratory symptoms get triggered by exercise, laughing, or allergen or cold air exposure. So even non-specific stimulants can also trigger the asthmatic attack. And very importantly, even viral infections can precipitate asthma attack by worsening of symptoms in this group of patients and causing acute exacerbation. The second component is a lung functional variability, which is entirely spirometry based, and it requires two things to be demonstrated. One, obstruction, two, reversibility. And obstruction will be when FEV1 over FVC ratio is low, lower than lower limit of normal, and FEV1 is also reduced. The reversibility is when we demonstrate after giving a beta 2 agonist 4 puffs and repeating the spirometry to see whether the FEV1 and or the FVC increases by 12% and 200 ml. So 12% is absolute and more than 200 or 200 ml. But in children, it is 12% only after a bronchodilator test. In adults, it is 12% and 200 ml. And recently, the ERS has tried to make it that only 10% improvement to make the diagnosis of asthma in the appropriate clinical settings is good enough for it. So, if there is a bronchodilator reversibility not demonstrated, then if you do a spirometry and give the patient inhaled corticosteroid and repeat spirometry at 4 weeks, in that case, even 12% improvement would indicate that this is a variable airflow obstruction. More the variation, more the reversibility on repeated testing, more will be the confident diagnosis. So if somebody shows you 30% reversibility versus 40% versus 10%, the level of confidence of making the diagnosis of asthma is much more if there is a higher reversibility, and this reversibility can be also seen in repeated testing. So every time reversibility coming up again increases the confidence in making the diagnosis of asthma. Why I am emphasizing this is because symptoms are so vague and respiratory, which are seen in almost all airway diseases, including COPD, bronchiectasis, bronchiolitis, small airway disease. All of them produce almost similar symptoms. So very important to remember is that when we test the patient on day 1, reversibility may be completely absent, and it is nearly in 50% of people. It happens if the patients are in exacerbation or had viral infection. It can also happen that patient has got very obstructed airway. It is also possible that there is a lot of mucosal swelling in the airways, which does not allow to demonstrate the reversibility. So if you do not get reversibility on day 1 of testing, it does not mean it is not asthma, and you need to do something else for that. And that is what is clarified in the GINA 2024, that if you have patients with respiratory symptoms, try to see that are these symptoms typical of asthma, and if they are, perform spirometry. Get the criteria of 12% and 200 ml reversibility in FEV1 or FVC, then it fulfills the criteria of bronchial asthma, then go ahead and treat the patient as asthma. But if the symptoms are not typical of asthma, you need to work for an alternate diagnosis. If you do not get reversibility on a spirometry, even if the patient is typically like an asthmatic, you ask the patient to undergo a repeat testing later, maybe 1 month or 3 months. And if still it comes out to be negative, we can do a bronchoprovocation test, which is these days we perform exercise-induced bronchoconstriction to be demonstrated by doing an exercise test. However, if all these tests are negative and you still feel this patient might be having asthma, then a trial of asthma treatment which requires inhaled corticosteroids. And if the patient becomes good, then definitely it is asthma. But if the patient doesn't, then obviously you need to look and treat for alternative diagnosis. But many a times spirometry is not available, or patient is in distress where it is not possible to do it. But patient looks typically asthmatic even if he has come to us for the first time, where an alternate diagnosis is unlikely. So in those situations, we are allowed to start empirical inhaled corticosteroid along with a short-acting beta-2 agonist, which comes as a combination of salbutamol and beclomethasone in our country. And give this to the patient and review the patient at 1 to 3 months. And at that point of time, do even spirometry and see how well the patient becomes with the medication which has been given to the patients. There's a little comment that in resource limited settings, it is a possibility that you may not have an opportunity to do spirometry based testing. And if that is not available, then a peak expiratory flow rate can be used, and more than 20% increase in PEF at 15 minutes after giving 2 puffs of salbutamol puts the diagnosis of asthma quite likely in that individual patient. And then you can treat the patient with inhaled corticosteroids, repeat peak flows at 4 weeks, which will also show improvement as well as improvement in the symptoms, which are all indirect measures to tell us that most likely the diagnosis is asthma only. But yes, we need a lot of training and good diagnostic equipments at a cheaper rate so that it is available to each and every physician for the diagnostic workup of a patient of asthma. It seems that the asthma diagnosis looks very clear clinically, but there is a long list of differential diagnoses which closely mimics asthma. A patient may have upper airway cough syndrome, where it is primarily because of chronic rhinosinusitis. They have sneezing, itching, blocked nose, and throat clearing repeatedly. Patient who has got cough, sputum, shortness of breath on exertion, and there is a history of smoking or noxious exposures or a biomass fuel, the diagnosis is most likely COPD rather than asthma there. If the onset of respiratory symptoms are sudden and unilateral wheeze is seen, then it is inhaled foreign body, which mimics like asthma. And many of these are called no asthma, but still they get treated as asthmatics. Recurrent viral infections produce productive cough and wheezing, and this can be a underlying disease, can be bronchiectasis there. If the patient is not able to lie down flat, has got more nocturnal symptoms, has got ankle edema with dyspnea, then cardiac failure should be kept in mind, and look for cardiac murmurs for particularly mitral stenosis, because that mimics asthma and it is called cardiac asthma. Excessive cough and mucus production with gastrointestinal symptoms can also be seen in patients with cystic fibrosis as well as gastroesophageal reflux. One of the group of tests which we do very frequently in asthma are the allergy tests. Allergy test is only to confirm the presence of atopy, and presence of atopy is not equivalent to patient having asthma. So remember, even if the skin prick test is positive, it does not mean patient has asthma, because patient should have those classical respiratory symptoms. And then in that case, if the patient has and on spirometry shows reversibility, you can label it as an allergic asthma because the allergy test is positive, but the diagnosis of asthma will be based on respiratory symptoms and spirometry reversibility. Generally, the skin prick tests are done to the common environmental allergens. It is simple and rapid to perform, has a high sensitivity in picking up what you are allergic to. You can do even specific IgE, which is no more reliable than skin test, but yes, some of the patients are uncooperative. They don't want to get skin prick test done, or they are on antihistamines which cannot be stopped and you can't perform a skin prick test. In those cases, you can ask for a specific IgE to the aeroallergens which you are suspecting as the cause of allergy in the individual patient with asthma. But I think I will underline this again, that a positive skin prick test or a positive specific IgE does not mean that it is asthma, does not mean that this is the allergen which is causing the symptoms, and it needs to be correlated with the patient's history to see whether this is the real cause of causing symptoms in the patient or not. That particular allergy is really directly linked to patient symptoms. That must be done before considering that the patient is allergic to this, and that is the one which is causing asthma in an individual patient. These days we are doing evaluation of asthmatics by doing exhaled breath nitric oxide. It is generally associated with the eosinophil count in the sputum and blood, but again, neither its high values confirm the diagnosis of asthma nor its low values rule out asthma. Generally, FeNO is higher in T2 high asthma. T2 high is the one which is allergic or eosinophilic asthma, but can be also elevated in eosinophilic bronchitis, allergic rhinitis, and eczema, and hence raised FeNO is not diagnostic of asthma. It's not elevated in T2 low asthma, and it is also lower in smokers, but it is transiently increased during viral infections, particularly of the respiratory tract, even in normal people, so that need to be kept in mind. The device which is being shown in this picture is a handheld device, small battery operated. You just need to blow into it at a specific rate, and it picks up the exhaled breath nitric oxide in parts per billion, ppb. More than 25 to 50 is considered as in the range where you suspect allergy is there in the airways of this patient. Above 50 is more likely to be associated with the allergic symptoms. However, 25 to 50 is considered as borderline, and less than 25 is considered as negative for raised FeNO. But it is still compatible with asthmatic patients, particularly T2 low, that is neutrophilic asthmatics, but also T2 high patients who are on treatment like high dose inhaled corticosteroids or oral steroids. Then I move on to the second part of the presentation, which is the treatment. So the goals of treatment of asthma is not just to quickly control their symptoms, but what we need to keep in mind is long-term symptom control in mind. So in that situation, there should be few or no asthma symptoms. If they appear, they should be quickly relieved. There should be no sleep disturbance. Patient should have peaceful sleep, and patient should be able to do all daily activities without any impediment. So physical activity should be non-hampered. Also, we need to not only look into what the asthma is presently troubling the patient, but also the long term of risk of patient having asthma, which can lead to development of exacerbations, loss of lung functions, and we need to see that this patient does not undergo repeated exacerbations. We try to improve their lung functions and try to stabilize them to the best lung function. Best is to keep FEV1 above 80%, but that's mostly very difficult in patients because they are non-compliant, and by the time they come for the treatment, some amount of fixed airway obstruction has already occurred in these patients. Very important on a long term is to see we don't need to use oral corticosteroids for these patients, because even if we give the corticosteroids for 2 to 3 times in a year, it is associated with 10% higher risk of diabetes, fractures, cataracts, hypertension. So oral corticosteroids is a completely no-no except for treating exacerbations, and if the exacerbations are coming despite the management compliance, then you need to look for the options. And of course, whatever medications we are giving, we need to minimize the side effects of them. So GINA has given primarily these 5 steps for us to treat the patients and 2 tracks. So you can see a track 1 is considered as a preferred track, primarily because the controller and the reliever therapy remains ICS based formoterol combination, so that we can utilize the advantages of what is called as single inhaler, which can be used for both purposes, for the maintenance as well as the reliever. It's called MART. Also is the term which is used for it. And step 3, step 4, step 5, all of them are on where it is formoterol based ICS combination. In step 3, low dose. In step 4, medium dose, and step 5, high dose. And as patient needs some extra medication to control his symptoms, in that case they can use the same inhaler, which is low dose ICS formoterol, considered as where formoterol is combined with 200 micrograms of inhaled corticosteroid, which is mostly in the form of budesonide. The other track is where the controller and the reliever medications are different. So in this group, the reliever medication is either as needed inhaled corticosteroid with SABA, which is again available to us, salbutamol plus beclomethasone, or as needed salbutamol alone. So generally, GINA is now recommending that we should use only track 1, because it has been shown that compliance is more if only one inhaler is to be used by the patient for daily maintenance as well as for his SOS therapy to relieve in the breakthrough symptoms. In track 2, you have step 3 in which you have low dose maintenance ICS and LABA, and here you have salmeterol fluticasone, medium dose salmeterol fluticasone for step 4, and high dose fluticasone and salmeterol for step 5. Now the basic issue about step 1 and step 5, step 1 and step 2 in both the tracks has come to where initially it was considered as they should use only salbutamol, but now it has graduated to where the recommendation is to use low dose ICS per formoterol in both step 1 and 2. So if it's mild, it can be on SOS like step 1. If it is step 2, it can be considered in the maintenance also, maybe 1 to 2 puffs a day, and SOS also in the same form. But in track 2, it is only the low dose maintenance inhaled corticosteroid, which is step 2. And then in step 1, you take SABA inhaler, but whenever you take SABA inhaler, you take ICS. Or if you have ICS SABA inhaler, please use that in step 1 on SOS basis, never a SABA or a LABA alone. So these are the two tracks. You can see that, and you can choose the step depending upon how much is the suffering of the patient as far as symptoms are concerned. Nocturnal awakening is there or not, whether this is once a night or more than that, whether the lung functions are low, and there has been a previous recent exacerbation. So depending upon the asthma control test, or we do this kind of assessment, which is based on symptoms during the day, symptoms during the night, and symptoms during the week requiring short-acting beta-2 agonist along with plus minus inhaled corticosteroid and a poor lung functions. You divide them into step 4, 3, and 2 and 1. And as I said, in 2 and 1, the strategy has changed. 3 and 4 is low dose, medium dose along with the LABA, and the same medication to be used on SOS basis. Very important point to remember is that asthma is often inappropriately treated as a recurrent acute worsenings which happens in this group of patients. So what you can see is it is treated as a recurrent acute disease rather than a chronic disease. So remember, asthma is a chronic inflammatory disease of the airways and needs a continuous treatment, not a recurrent acute treatment with no treatment in between, either from our side or from the patient side. I know most of the patients, when they feel well, they leave the treatment and come back only when they are acutely sick, and that is why the disease has become more like a recurrent acute disease rather than understanding that it is a chronic, persistent inflammatory disease where we need to make the patients also understand that. And this leads to lot of exacerbations, hospitalizations, and acute attack of asthma, causing a huge amount of burden to patients, their family members, health system, and even the economy, and poses these patients on an especially high risk of mortality. And because they have to be treated quickly and to save their lives, oral corticosteroids or IV steroids are given. And even if, as I said, that you have 4 to 5 time lifetime courses given of oral steroids, it has a cumulative risk of these adverse events of oral steroids, which I have already enumerated: diabetes mellitus, hypertension, cataract, osteoporosis, and many other things like that. So although asthma morbidity and mortality is largely preventable, but mostly we are working on the, when there is an acute symptoms, take care of them with the acute care setting, in the acute care settings. So how do we assess the patient once we have made the diagnosis? We want to see how much is the symptom control. How much are the symptoms during the daytime? How much they are during the night time? Activity throughout the day, how much it is limited, and is patient using a short-acting reliever therapy 2 or more than 2 times a week. And we'd ask about all these things in the last 4 weeks and ask it on every visit and do a direct questioning. We have ACT, ACQ scores, so we can use them. And on the basis of this symptomatology and the SABA use, we either call them well controlled, partially controlled, or uncontrolled. But very important is that we need to remember that even if the patient looks milder variety of asthma to us, there are certain factors which need to be considered as they are indicators of future risk of exacerbations in this patient. And those exacerbations can be actually life-threatening. So those patients who are using high dosages of SABA and low dosages of ICS are at high risk of exacerbations. Pregnant ladies, patients with food allergy and multimorbidity are again at high risk for exacerbation. Those who continuously get exposures of smoke, allergen, and pollution, again they are at high risk of exacerbation. Psychosocial support is, if not available, again is considered as a high risk for exacerbation. And those patients who have got high type 2 inflammation, like eosinophil counts are high in the blood, or exhaled breath nitric oxide is high, that are also indicators that most likely this patient will have more exacerbations and more intensively needs to be treated. and any patient who has any history of severe exacerbation which required either ICU admission or intubation and mechanical ventilation forever will have a risk of getting into similar situation again, and at very high risk for the future admission, hospitalization, RICU requirement, as well as life-threatening attacks of asthma. So these patients are at risk, so we need to treat them more aggressively. Any patient who has got low FEV1, that itself is an indicator of future risk of exacerbation. Generally, we treat them very aggressively if they have an exacerbation in the last 1 year. Look at their poor adherence, because that may be one of the factor leading to recurrent exacerbations, even incorrect technique, as well as underlying chronic sinusitis as a comorbidity be a factor for future repeated exacerbations. And smoking, whether active or passive, are also considered as an important risk factor for continuing exacerbation. But low FEV1 is always to be remembered, that these patients need to be aggressively managed. Even if they say they have very few symptoms, their asthma seems to be under well control, but because of poor lung functions, they need to be aggressively managed. Multimorbidity assessment is also very important, because asthma very rarely comes alone. It is mostly associated with either pulmonary or extrapulmonary morbidities. So in the pulmonary, we have rhinitis, rhinosinusitis. In extrapulmonary, it is obesity, GERD, obstructive sleep apnea, anxiety, and depression. This is a snapshot of step 1, step 2, step 3, step 4, and step 5 of asthma. Most of the times we are trying to treat them with formoterol based ICS combinations. These are required twice a day, but because some people and some patients are not happy with twice a day and wants of once a day, so these days we have once a day, and GINA talks about them, whether it is based on indacaterol or vilanterol, to the group of patients who seems to be becoming non-compliant on twice a day therapy, where their schedule, work schedule doesn't allow them to use it twice a day, so that this is one of the options for those group of patients. What about oral bronchodilators? So GINA very clearly says there is absolutely no role of oral bronchodilators, whether you talk about beta 2 or you talk about theophylline. They are not to be given. Mostly they are slow onset of action, less effective, and have more adverse events and effects. And they do not treat airway inflammation, which is the characteristic of asthma. So you need to get to the grassroots of the pathophysiology of asthma, that is the inflammation. And inflammation is basically which requires inhaled corticosteroids in these patients, not oral steroids, for its obvious side effects. Now, what are the doses of ICS which are considered as low, medium, and high? The reason being, medium to high dosages are associated with long-term morbidity. So you need to try to keep your patients to at least medium to low, and try to see them that you can bring them from high to medium with whatever means you use to do that. So if you look at the two most common ones which we use, that is budesonide, then its medium dose is up to 800, more than 800 is high, and up to 400 is actually a low dose. If we talk about fluticasone, up to 250 is the low dose, up to 500 is the medium dose, and more than 500 is considered as the high dose. These are the most commonly used ones which we are using. Furoate is about 100 and 200, only two dosages, low to high. And these are the most common ones which we use in our daily practice. So in step 1, now there is a different approach. Previously, the GINA used to recommend that use salbutamol on SOS basis. But it has been seen in the Sigma 1 trial that there is a large reduction in severe exacerbations in the group of patients who are treated with ICS along with SABA rather than SABA alone. So very important point to remember here is that it's not only moderate to severe asthmatic patients who are prone to develop exacerbations. 1/3 of exacerbations occurs in patients who have got mild intermittent asthma. That is step 1 or step 2. So there is a high level of recommendation given that the patients, whenever they get salbutamol, they should get inhaled corticosteroid also along with it. Whether they get formoterol, then also there should be add-on inhaled corticosteroids along with it. There are countries where they are not available as a combination, so there is a problem to give 2 inhalers at that point of time, but luckily we don't have to go through that kind of issues. In step 2, now there is again in the MART, what we are talking about is that if you use budesonide and formoterol combination, which is low dose, regularly as well as on SOS basis, whenever there are breakthrough symptoms, we find that it is non-inferior to low dose ICS plus as needed SABA, which was the initial recommendation for step 2 in GINA. But there is a direct evidence that there is more reduction in severe exacerbations in the group which is given inhaled corticosteroid along with the beta-2 agonist rather than beta-2 agonist alone. So these patients, to prevent severe exacerbation and avoid need for daily ICS in patients with mild or infrequent symptoms, they can use ICS and formoterol either on the maintenance or both maintenance as well as reliever therapy. And of course, this makes the life of the patient very simple because they have this kind of a behavior where they can actually depend upon that inhaler on daily basis as well as on the emergency basis. Once we decide that this patient goes for a step 1, step 2 or step 3, 4 treatment, then it's not all that set and forget about it. We need to reevaluate the patient. So generally we do it at 1 to 3 months, where we not only confirm the asthma control of the patient, but we also look back and see whether we have not missed the diagnostic criteria, we have fulfilled the criteria, and there is no ambiguity about the diagnosis of asthma. Symptom control and modifiable risk factors are evaluated at each visit. Comorbidities are proactively looked into and addressed to, and very importantly, at each visit, inhaler technique and adherence need to be checked because it varies from visit to visit. And of course, you need the patient's caregiver, and their preferences have to be kept in mind when we choose the therapeutic regimen for an individual patient of asthma. Whatever are the modifiable risk factors and comorbidities, they must be adjusted on the next visit. Non-pharmacological strategies should be put into place. Asthma medications should be checked for that ICS is being given to them, and a lot of education, training and action plans needs to be given. And we keep reviewing on every visit, how are the respiratory symptoms improving, or are they there, or they have completely gone. The history of exacerbations, any side effects of the drugs which we are giving, are the lung functions acceptable or not, have they improved or not, comorbidities of the patient, whether they have been all picked up and addressed adequately. And of course, at the end of the day, patients will only take the medication if they are happy with the medication. If they are not happy, they won't use that. Moving on to the assessing the response. As I told you, we generally do at 1 to 3 months, and then if the patient is doing stable, every 3 to 12 months. So sometimes even 1 year later we call them. But during the pregnancy, closely monitor these patients, and after an exacerbation, see the patient within 1 week and closely monitor for next 1 month, because that's the time when they can have another exacerbation. Stepping up the treatment, whenever we do, we wait for 2 to 3 months. If sometimes the patient has a viral infection or exposure to something which causes acute worsening, then you just need to step up the therapy for only 1 to 2 weeks and then bring back to its previous level. So sometimes day-to-day adjustments are possible when we use the ICS low dose with formoterol as a maintenance as well as reliever therapy, which is like with the formoterol and budesonide combination. And if the patient shows stability in 3 to 6 months time, generally 3 months is the minimum period required, but you need to be very cautious. If the patient has a future risk of exacerbation by all the factors which I've told you, including low FEV1, poor behavior, multiple comorbidities, likely to be non-adherent, poor technique, and so many other things, then don't bring down the therapy so soon. Wait for a little longer period and very cautiously decrease the dose of inhaled corticosteroids, whereby you closely evaluate the patient for not losing the asthma control by having symptoms and not landing up into an acute exacerbation. Then comes the last thing, which is GINA step 5. What do you do in GINA step 5? These are the group of patients who are on high dose ICS and LABA. You can add LAMA to it. Some of the patients do respond well, some of the patients do not respond well. But what next? Most of the times the next choice available is to use oral corticosteroids. So these patients who require oral corticosteroids, the idea in GINA step 5 is not to give it because of its side effects, and choose them to give biologicals as per their phenotypic and endotypic thing. We know it is an expensive thing, but you need to use in this group of patients to decrease their morbidity and mortality. Which are the patients of severe asthma who are suitable for biologicals? These are the ones who have type 2 inflammation in the airways. Type 2 inflammation is either driven by IgE or by eosinophil, and they are called allergic phenotypes. What are these allergic phenotypes? They have early childhood onset or early adulthood onset. They have multiple allergic comorbidities like atopic dermatitis, allergic rhinitis, chronic sinusitis, nasal polyposis, ABPA, EGPA. All this kind of inflammation producing various kind of manifestations are exclusively sensitive to oral corticosteroids. You give them and the patient becomes all right. You decrease the dose, you stop the steroids, and the symptoms come back. That's typical of type 2 or allergic or an atopic phenotype of these patients. In these group of patients, we have a 3 class of biologicals or monoclonal antibodies. One is called omalizumab, which neutralizes the IgE, circulating IgE, which causes IgE mediated mast cell release of histamine and other chemicals, which causes allergic attack in the asthmatic airways. It can be blocked by giving omalizumab. The other thing what happens is that there is a T2 inflammation which is driven by T2 cells, which calls for interleukin 5 to recruit eosinophils, mature eosinophils, as well as lead the eosinophils to the airways to cause damage. So to neutralize the interleukin 5, you have monoclonal antibodies against IL-5, which is called mepolizumab, and IL-5 receptor on the eosinophil is blocked by a monoclonal antibody called benralizumab. So when IL-5 reaches the eosinophil to stimulate and degranulate the eosinophils, it finds benralizumab is sitting there and doesn't allow it to degranulate. And there is a third variety of it which blocks the 2 other important cytokines which initiate the allergic inflammation in the airways, that is interleukin 4 and interleukin 13. Dupilumab is one of the monoclonal antibody which is a dual blocker. It blocks interleukin 4 as well as 13 because it binds to their receptor site, which is shared by this both the cytokines. So there is a shared receptor between interleukin 4 and interleukin 13, and it is blocked by dupilumab, and hence it has got very good effects even in the patients who do not have classical eosinophilic or allergic inflammation. Even those who have got little T2 low, dupilumab works even in those group of patients. And then finally, it is their interaction of respiratory epithelium with the allergens from the atmosphere which leads to the downstream cascade of this allergic inflammation, and that is through the cytokine which is called TSLP. And now we have TSLP monoclonal antibody also, but not yet in India, which is called tezepelumab, and it is effective again whether you have T2 asthma or non-T2 asthma. It can control the inflammation and improve the outcomes in any type of severe asthma. When we need to choose the biologicals, we need to see what they can do. So they roughly reduce exacerbations by 50 to 60%. Most of them are able to reduce the need for oral corticosteroids in the maintenance dose as well as oral corticosteroid burst. Some of them may completely eliminate the need of oral corticosteroids in about 50 to 60 or 70% of patients. It also improves the lung functions, quality of life, asthma related quality of life, and certain other comorbidities when they are present. They also get improved. Not only the asthma part gets improved with this biological, but their associated comorbidities. Like a patient of severe asthma, which is IgE mediated, if he has nasal polyposis, chronic sinusitis or urticarias, omalizumab will act at all of them. If patient has EGPA, sinusitis, nasal polyposis, then mepolizumab will eliminate everything. And there are many other things which are also equally effective with benralizumab. And mind you, mepolizumab and benralizumab both belong to same group because they are virtually eliminating the interleukin 5 related effects on the eosinophils. What do we do after starting the drugs? We sit off about 4 months, that's the minimum period, and then we reevaluate the patient. How is the symptom burden now after 4 months? Are there any exacerbations in the last 5 months? What are the side effects of the treatment? Has the lung function improved? Has the treatment intensity, like these patients are on so many drugs, has been able to reduce by using the biologicals for 4 months? And how much is the satisfaction scoring of the patient? And if they have any concerns about its cost and its safety, all need to be addressed. If we find that things are going in a right direction, patient is showing good response, we continue the therapy. If we find that the patient is really not doing good, he's as bad as he was 4 to 6 months ago, then we try to stop that biologic and try to see that maybe the other biologic will work if the patient has that phenotypic characteristics. However, if we are not clear at 4 months, because patient says some improvement, not much improvement, you need to extend the therapy for 6 to 12 months to see an adequate complete effect of these biologicals. How do we step down? So generally never a step down in less than 3 months, and you give a little more time to those patients who have got high risk factors for exacerbations. You need to choose an appropriate time. Always try to step down when the patient's worst period is not there. So generally we ask the patient which are the worst months in the year, and don't try to titrate the therapy down during those months. And this is always a therapeutic trial. So we keep documenting that they are still doing good, and at the first instance when we feel that they are not doing well, we need to go back to their previous dose. And of course, when we stop drugs one by one, ICS is the last of the drug which is continued and not stopped in patients with asthma, because it's a chronic airway inflammatory disease. So I'll give a couple of take-home messages, which is like asthma is a chronic inflammatory airway disease. Remember that two words, chronic as well as inflammation. And in the diagnostic approach, we need to demonstrate the history of respiratory symptoms which are variable, and FEV1, FVC on spirometries, which is also variable from time to time, or on giving a bronchodilators to the patient. We can do a bronchial hyperresponsiveness testing, but it is very difficult. Biomarkers, particularly FeNO, absolute eosinophil count in the blood, are very important these days, because these are considered as biomarkers for using biologicals in patients with severe asthma. Inhaled corticosteroid is the cornerstone of treatment, and in step 1, as needed treatment requires add-on inhaled corticosteroids with short-acting or long-acting beta-2 agonists. In step 3 and step 4 treatment, it is low to medium dose inhaled corticosteroid, which on long term are considered to be safer options. But in step 5, where we have high dose inhaled corticosteroid, LABA, if the patient continues to be uncontrolled, we give them LAMA and see if they improve or not. If they do not, then of course the treatment would be upgraded to phenotypic and endotypic based classification of the patients into T2 high or T2 low, and choosing biologicals. But severe asthma is a real challenge, because these patients are at threat of life, exacerbations which are very serious, requiring hospitalization, ICU admission, mechanical ventilation, and loss of life. So at the moment we have T2 high asthma available, biologicals are available for T2 high asthma. T2 low asthma is very uncommon in India. We have seen only about 15% in our study from our center, but for them also in future we are going to get biologicals to treat them. But in the meantime, the most important message would be that continuously assess, adjust, and review your asthma patients every 1 to 3 months till the time they are stable for almost a year, where you can increase the gap of follow-up from 3 to 6 months, and 6 months to 9 months, and 9 months to 1 year. With that, I would like to thank you all for this opportunity listening to me, and I'm open to all the questions. So I think I can take questions from the last management of cough variant asthma. That's the last one. So cough variant asthma, previously was not very clearly defined. It was considered as any patient who keeps coughing and responds to bronchodilators and inhaled corticosteroids. That's what it was. It was difficult to difficult to diagnose because their lung functions are mostly normal. Reversibility is not able to be demonstrated, and the respiratory symptoms are not classical of asthma. Now these days we are realizing that this cough variant asthma is more and more small airway disease asthma, and we have a targeted therapies available to them. So we treat them with extra fine particle inhaled corticosteroid and a long acting beta 2 agonist to target the small airways, which is like much better than giving oral steroids which you used to give to the previously to the patients of cough variant asthma. Then there is another question which is on
Dr. Sanjay,
yeah. Ha Sanjay. Hi.
Yeah. Hi. So wonderful lecture, sir, as usual. So since it is a classical teaching program for the students, I would like to give few words about the newer tests regarding the bronchial hyperresponsiveness for their knowledge.
So bronchial hyperresponsiveness.
Yeah.
So bronchial hyperresponsiveness is classically used to be tested with the histamine test, basically histamine and methacholine challenge tests. So serial dilutions of this is given. This is a very potent constrictor of the airways, and you demonstrate the fall in FEV1 in these patients. But neither the drugs are available to do it. So we started doing exercise induced bronchoconstriction test, in which you make the patients run straight for 6 minutes at a fairly fast speed. Either you do it on a ground or you do it in a treadmill test, and you have an spirometry before, and you do spirometry after completing this 6-minute running test, and you keep doing it at after stopping the exercise, then at 1 minute, then 5 minutes, then 10 minutes, then 15 minutes, and then go up to 30 minutes. So within 30 minutes, a fall of more than 12% of FEV1 is considered as a positive test for exercise induced constriction. Now we have, without doing an exercise, we have what is called as a hyperventilation test, bronchoprovocation, which is done by hyperventilation. So it's a machine. Only thing is, in the hyperventilation you will wash out a lot of carbon dioxide. So this machine will provide you with the air for inhalation which has got that level of carbon dioxide which is like 4%, so that you don't get into hypocapnia due to hyperventilation. And it affects the same way as exercise induced bronchoconstriction, and you keep doing the spirometry after finishing your test, which generally takes again about 5 to 6 minutes for these patients. And you generally give them maximum voluntary ventilation up to about 75 to 80% of it to achieve a good bronchoprovocation test. And again, a fall in FEV1, which is of 10%, is considered as positive for a bronchoprovocation test on an exercise testing.
Sir, few words about iOS.
Okay, so now the new the diagnostics which are coming up has oscillometry, which has got a sound waves of different frequencies which are sent into the airways through the machine which generates these sounds. And when they travel into the airways, depending upon how much resistance they get because of the because of the constriction of the airways, when they come back, they are picked up by the transducer, and whatever the deformation of the sound wave which happens tells us whether it has happened in those frequencies which were there in the large airways, or in the medium airways, or in the small airways. So 5, 10, 15 and 20 hertz frequencies are all sent together either in iOS or FOT. Both are the similar techniques but use different principle. But they send sound waves of these 4 frequencies, and we know that the frequencies of 5 hertz will reach right up to the end. So it will give us an idea of resistance at 5 hertz, which is of the entire respiratory system, while what is done with the 20 hertz, which is called R20, is only of the large airways. So you subtract from R5 to R20 and you get the resistance in the airways, which is supposed to be about 10%. So if it is more, it will diagnose a small airway obstruction. If you find that the R20 is very, very high. That shows it's a large airway obstruction. And if you find both the R5 and R20 are raised, then it is both large as well as small airway obstruction. You can do a reversibility also in that. So you use the same 4 puffs of salbutamol inhaler, repeat the test, but here instead of 12% or 10% or 200 ml improvement in FEV1 or FVC, we look for improvement in the other parameters which are considered as small airway index, AX or R5, R20. But you need to have a threshold of about 30 to 35% because the magnitude of change which happens is significantly very high in comparison to what we see in spirometry. Idea is that spirometry can be completely normal and patient can be still asthmatic. Can you pick up the disease in this group of patients? We can pick it up by oscillometry. So that is why oscillometry has become an additional equipment. At the moment, I will say add-on equipment which can be added to the diagnostic armamentarium for the patients of asthma.
Thank you, sir. There is one question in the chat box that clinicians do routinely tests like blood eosinophil and total IgE in asthma. Is it any role before patient getting diagnosed at severe asthma?
Actually, there is no role for doing it because the treatment of step 1, 2, 3, 4 does not account for anything, whether it is IgE raised or not, whether eosinophil counts are raised or not. But yes, in some of the situations, these are helpful to pick up the other comorbidities which are related to it. So if the serum IgE is very high, you might get a hint that patient might be having ABPA. And when the eosinophils are very high, then you can get a hint that patient might be having EGPA, eosinophilic granulomatous polyangiitis. So they might help in that way. But in making a decision that whether, like suppose if I ask you that if IgE is low, if eosinophil count is low, will you not use inhaled corticosteroid in that patient? The answer is no, you have to still use the ICS only. So actually it does not add to our decision making as far as the treatment is concerned. But yes, for the other problems related to asthma, for the differential diagnosis of other conditions, it may be of great help. So it might be required when patients are not doing well. So if they do well, then there is no problem. But yes, in India, you may get a hint about eosinophil counts being high because of the parasitic infestations, and you might like to do certain more evaluations for that. But most of the times, I think it is in our habit, we write serum IgE and absolute eosinophil count. They only indicate that there is a T2 inflammation. It does not tell us whether T2 inflammation is causing asthma or not. It also does not tell us that our choice of using inhaled corticosteroid is going to change if it is T2 low. So ultimately, it's not a therapeutic decision. It is not a diagnostic decision. It is only for phenoendotyping, and that is for step 5 severe asthma only.
Thank you, sir. Thank you, sir, for very nice deliberation. Dr. DP Singh, sir, is here. He would like to make some comments.
That's the most wonderful talk and very comprehensive, touching from the beginning to the end, and also satisfying the queries from our students and even our experts. I think this is a wonderful session. We have learned many things from your talk. Yes, sir. Thank you very much.
We would like to request Dr. Deepak Talwar sir to take some more classes for the benefit of the students.
Definitely. Somebody has asked me that you have read mitral stenosis for a cardiac asthma. Yes, it is a heart failure. So it's anyways, whether it is because of mitral stenosis or a poor ejection fraction, we all do anti-pro BNPs these days. So that's a cardiac asthma. You are 100% correct, Saurabh.
Okay.
Thank you, sir. Thank you very much. Thank you for accepting our invitation.
Yeah.
Friends,
And next week we shall have talk of Dr. Rajadhar on bronchic cases. Next Wednesday, please come. You are all invited. Dr. Rajadhar on bronchic cases. Next Wednesday.
Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you, everyone. Thank you very
you.
much. Thank you, Dr. DP Singh. Thank you, Dr. Kamlesh Tiwari. Thank you, everyone who joined in and gave 1 hour of their life to me today on this platform. Thank you,
we are
everyone.
thankful to you, sir.
Thank you, sir. Thank you.